It's Mari McInerney from Croaky here at the Medicines Management Conference in Adelaide, and I'm speaking here with Elizabeth, one of the presenters in the last session. Elizabeth, could you introduce yourself, please?
Yes, hello everyone. I'm Elizabeth Sue and I'm a pharmacist with the Medicines Optimisation Service at Austin Health in Melbourne.
Fantastic. Now, you just gave a presentation on deprescribing. What was the issue?
Yes, so we're looking at deprescribing medicines that have sedative or anticholinergic properties. So basically side effects that can really impact the quality of life in older people. So medicines with these sorts of side effects, when you have a lot of them on board, they can lead to things like delirium or falls, which can then have really bad impacts on patients' quality of life because it might lead to hospitalisation or placement in aged care homes. So what we've been trying to do is look at what we can do to help deprescribe, which means to stop or reduce these medicines when they're no longer needed, or if their side effects might be outweighing any potential benefits that the patient was trying to achieve.
And what do they tend to be prescribed for?
Yeah, so some examples of medicines that have sedative or anticholinergic properties include opioids, so medicines that can make you really drowsy. Also some antidepressants as well have anticholinergic type properties, so they might affect people's alertness or their ability to pass urine, for example. So yes.
So what did you do?
Yes, so what we did was we implemented a workflow between our pharmacists and doctors on our geriatric rehabilitation wards to try and address these issues. So what we had was pharmacists using some validated tools to look at patients or to identify patients who had these sorts of medications, and then to make recommendations to our doctors and with the pharmacist, with the patient involved, to look at whether we could stop these medicines or reduce their doses while the patient was in hospital, and to make sure that any changes that we made were really clearly communicated both to the patient's GP and to the patient and their family as well, just to make sure that any changes we made were sustained after the patient went home.
And probably just to take a step back, why would that not already be routine?
Yeah, so look, I mean, it is something that everyone strives to do, but sometimes within all the things that we're trying to juggle to organise for the patient, it's really useful to really standardise this workflow. So pharmacists are medicines experts, and so what we can really try and do as part of a medication review that we do for all patients in the hospital ward is to really make sure that sedative and anticholinergic medicines are something that we target as part of our medication review, because we know that they're a problem for older patients.
Great. You had a rather natty little name for the project. What was that?
Yes, so it's called Partnered Pharmacist Medication Deprescribing. So something that's been happening a lot in hospital is pharmacists helping our doctors with charting medicines. What we're looking at is deprescribing. So when medicines are actually no longer needed, our pharmacists helping to reduce those medicines.
And you called it Do It?
Oh yes, we also have an electronic tool that was helping our pharmacists to identify medicines that could be deprescribed, and that tool is called the Deprescribing Opportunity Identification Tool, so Do It for short. And what we like to say at our hospital is that pharmacists and doctors do it better together.
Fantastic. Now, what were the results?
Yes, so we had a trial of our tool and this workflow this year between April and May 2024, and what we found was of the patients that had anticholinergic and sedative medications, about 70% were able to be reviewed by our pharmacist directly, and then of those patients, about 40% were able to have a medicine stopped while they were stopped or reduced while they were in hospital, just meaning that we could take action to do that while they were receiving rehabilitation.
Great. And lessons for the future?
Yes, so I guess, look, we're all aiming to get the best out of our medicines. So one thing is to start medicines when they're appropriate, but also the other end of it is really to try and stop medicines when they might potentially not be as beneficial as they used to be. So that's something that we're striving to do at our hospital, and we're really happy that our tool has been able to help with that.
And do you see that being scaled up elsewhere? Is there interest elsewhere?
Yes. So this tool is based on some tools that have been available in other states as well. So certainly everyone's striving towards the same goals. We would hope that our tool might be able to be adapted to be taken up by other services that may not have a tool of their own.
Fantastic, Elizabeth. Anything else that we should know?
Look, I would just say that, pharmacists are always really happy to help. So if you've ever got questions about medicines, feel free to reach out to a pharmacist. We love to talk about medicine, so please talk to us.
Fantastic. Thank you very much.